All right, let's talk a little bit more about blood pressure, how it's regulated, and how it can lead to shock. Shock here at the bottom. Um, all right, yeah, that's pretty gross. Weird to think we all got one of these ticking on inside of us right now. Grody. Osmotic pressure. Okay, so you'll remember from Gin Chem, osmotic pressure is one of our four colligative properties. Pi equals IMRT. And effectively, if we have a large concentration inside some container, some volume, and there's a semi-permeable membrane, water will want to rush in. This is the most important net effect. So water would rush in here, and boom, what do you know? You got more water. So osmotic pressure is technically defined as the theoretical pressure needed to prevent osmosis. So if we exert enough pressure, that'll prevent the pressure of water wanting to come in. Now, typically, we never actually have this pressure. It's theoretical. So at the end of the day, this is typically what happens. Water does rush in rather than little invisible green men pushing on a thing to prevent, against a cell membrane to prevent water coming in. So this is, osmotic pressure, high concentration means water moves to that region. Boom. Boom, boom, bing, bing, boom. Exactly. All right. So two types of pressure, hydrostatic pressure and osmotic pressure. So on the arterial end, hydrostatic pressure is just if you fill up a balloon with water, the water particles pushing against the balloon, that is the hydrostatic pressure. So it's classic quintessential pressure. So there's so much fluid here, more than there is in the interstitial space pushing back in. So it wants to push out. On the other hand, we do have some interstitial fluid with hydrostatic pressure trying to push water in. It's less, but still it exists. Similarly, there's so much little salt particles and especially albumin. So if you hear oncotic pressure, that's just talking about the osmotic pressure due to proteins, which is mostly what the osmotic pull is from, and mostly that's albumin. So osmotic pressure is basically oncotic pressure, which is basically albumin. Again, this is like a negative sucking pressure. So it wants to pull the fluid in, and then we also have little particles in the interstitial fluid wanting to pull the fluid from the blood into the interstitial. So from the plasma side, hydrostatic pushes out, osmotic pulls in, and then from the interstitial, hydrostatic pushes into the blood and the osmotic pulls out. So how does this work out at the end of the day? At the arterial end, we have a net efflux, and it has to do with the fact that the net hydrostatic pressure is like 35 compared to the osmotic pressure pulling in of 25 means that we're going to have a net 10 pressure pushing fluid out. So this is helping us deliver water and glucose and oxygen and whatnot. It kind of overshoots, it overcorrects. So the osmotic pressure actually never changes, the net osmotic pressure. But the hydrostatic pressure, we pushed out too much fluid, so now it's 18. So now it pulls -7 back in. So we push out on the arterial side, we pull back in on the venous side. Notice also these numbers, +10 and -7, we're pushing more out than we're pulling in. Well, if you think about that over time, the net effect of pushing out more than you pull in for the interstitial fluid means it would just swell with fluid. That's what we would call edema. And this obviously does happen under some circumstances. Why do we not always have edema? It's because of our lymphatic system. It's a drainage system. It picks up all the superfluous fluid, and it just eventually, at our cervical area, it just will reconnect with the circulatory system. And so causes of edema, remember we have these many factors. If the hydrostatic pressure is too high, this will push too much fluid out. So this could be in congestive heart failure, the fluid backs up if you have right-sided heart failure, or it could be, you could talk about pulmonary hydrostatic pressure being too high if we have left-sided heart failure. Kidney dysfunction, we have too much renin, angiotensin, aldosterone system. The ROS system is elevated, and so this is increasing the hydrostatic pressure due to increased fluid because of aldosterone, and also angiotensin 2 is increasing vasoconstriction, increasing the hydrostatic pressure. Pregnancy also increases the hydrostatic pressure. Also, the osmotic pressure pulling blood and fluid back in could be too small. Liver failure, liver makes albumin, not enough livid. You look at people who are alcoholics and have severe end-stage cirrhosis, they're going to be a little bit swollen, and one of the reasons is because they can't produce albumin, so the osmotic pressure stinks. Malnutrition, kwashiorkor, if not just being hungry and starvation, but not having enough nutrients, specifically enough protein. We need the protein to make albumin, and so in developing countries where people are malnourished, their liver won't be able to produce an adequate amount of albumin, so the pull inwards is not sufficient. Increased capillary permeability. I guess infections can cause this. Burns as well can cause this. And then lymphatic obstruction. You could kind of guess which one. Is it this one or this one where the lymph nodes were removed? It must have been this one, right? Because there's edema and there's swelling. Often this is because of malignancy. Maybe it's a sentinel node biopsy. Maybe there's a lymphoma. Maybe there's radiation and it damaged some lymph nodes. But whatever the case, you're not draining properly on their right leg, hence the edema. Pitting edema is where you press into it and then you just leave it and a pit remains for a second or a couple of seconds after you remove your finger. This is just classic sign of edema, also known as hyperperfusion. We're pushing too much blood out. So shock is really just the opposite of edema in a sense. It's effectively hypoperfusion. So if this was too high and too low, then I guess it would stand to reason that it's just the reverse of all four of those. Yeah, you would think, but realistically, it's actually just these two. And in fact, this one, it's really not even that. It's actually really an increased capillary permeability. The reasoning, it's a little bit weird. It's kind of like DIC, disseminated intravascular coagulation, where we consume so many clotting factors in one region that in another region of the body, when we do need a clot, we already used up all of our reactants, so there's no clotting that can occur. Similarly, if you push out too much fluid in one part of the body, it's difficult to have adequate perfusion in another part of the body. But for the most part, this is far and away the most important factor for shock. So hydrostatic pressure too low, what could contribute to that? The heart does not work. That's cardiogenic shock. If there's just no blood, it's missing. This is hypovolemic shock. If there's an obstruction, if there's a block, this is going to be obstructive shock. And if the blood's in like a weird, inappropriate place, right, whether it's distributed to the non-vital organs or it's distributed to the interstitial fluid when we want it to remain in the plasma, this is kind of what I meant when I said that there's a DIC. This is distributive shock, of which there are three subtypes: sepsis, anaphylaxis, and neurogenic shock. You can picture it this way. Hypovolemic shock, there's not enough volume. Obstructive shock, there's something preventing blood from getting back to the heart and being pumped. B, cardiogenic shock, it's just not working. And then C, distributive shock. This is probably the trickiest one to conceptualize. Blood is, again, being shunted away from the vital organs towards the non-vital organs. So both a combination being pushed towards the non-vital organs and kind of like the DIC concept, it's being pushed into the interstitial space too much of certain regions. So now that means at the end of the day, we do have less fluid for to maintain an adequate hydrostatic pressure. It's cardiogenic shock, heart sucks. This is like severe heart failure. Heart failure is kind of like a chronic concept. Cardiogenic shock is like more acute. Like for whatever reason, right now, your heart is really, really, really not getting enough blood out. We have techniques that our body automatically does called compensation, vasoconstriction, right? It's just trying to increase the hydrostatic pressure to get adequate perfusion. Vasoconstriction, it can make your heart pump more strongly and the rate increase via catecholamines and also the Ross system. Now, this might work a little bit in the short term, but I would say it's myopic because it's going to, I guess there's trade-offs, but it's going to damage your heart in the long run, especially with heart failure if you have all of these techniques that are putting more stress on an already stressed heart. So MI, cardiomyopathy, which can lead to heart failure when the heart's just not pumping enough, myocarditis or arrhythmias can all lead to cardiogenic shock, especially VTAC and VFib. Hypovolemic shock. So most of this is just, someone's in a car accident, they're losing a lot of blood. They could also maybe have a colon cancer, and then whether it's cryptic or non-cryptic, they are slowly losing blood, over the course of maybe a year in their stool, and then now they just don't have enough blood fluid, and this is the same thing. So that's hemorrhagic from bleeding. Non-hemorrhagic, so maybe you have a pathogen causing massive diarrhea. You're still losing more fluid than you're taking in. Burns, so you're increasing the vascular permeability, which effectively means that fluid is leaking out into the interstitial space, so you're losing blood volume. So some people argue, and I don't really care, but just be aware of it, some people argue that this technically makes this a distributive shock because it's being distributed to the interstitial space in certain areas, and it's not in the plasma where it should be. Again, this is one of the reasons that I made the analogy with DIC. Maybe it's an imperfect analogy, but it at least works for me. And then salt wasting. If for whatever reason your urine is particularly high osmolarity, this is going to increase your urine output and lead to a low volume of your plasma. Distributive shock. So vasodilation, I guess it's a couple things. If for whatever reason you have massive vasodilation, your blood pressure is going to go down. That's one thing. A second thing is the loss of plasma to interstitial fluid. So this is kind of one, loss of plasma to interstitial fluid. This is kind of the DIC concept. Both of those contribute to less blood pressure. Also, you know what's really important? My heart, my lungs, my brain. You know what's not important? My skin, my fingers. So blood is being shunted away from the important organs towards the less important organs. So what can cause these three things to occur? Sepsis, so a bacterial or maybe viral, usually bacterial infection, is going to cause cytokines. They're going to induce vasodilation and redistribute where blood should be. Anaphylaxis, so an allergic response. Histamine induces vasodilation, so same general idea. And the neurogenic shock, your central nervous system is not functioning, and your central nervous system is necessary to vasoconstrict. And if you can't vasoconstrict, you know what happens? By default, you vasodilate. And all right, all of these three kind of summed up. Hypovolemic shock is, you're hemorrhaging or you're dehydrated or there's burns. The heart rate is trying to compensate, right? It's saying, hey, our blood pressure is really low. Let's pump out more. Why are you cold? Because you're distributing blood. Your body's trying to redirect blood away from your skin and towards your more important organs. And because it's going away from your skin, the blood is what gives you like a nice color. And so pale would just be because you're not getting enough oxygen to your skin, your peripheral extremities. And clammy is your sympathetic nervous system is kicking into gear to try to increase your heart rate and vasoconstrict. Your preload is down because pulmonary capillary wedge pressure. So this is really just measuring how much is going into your right atrium and your right ventricle. So this is your preload. It's going to go down because you don't have enough blood. That just sort of checks out. And yeah, sure, our heart rate's gone up, but it depends what the numbers are. But very likely that we've just lost so much blood that even though the heart rate's increased, the cardiac output overall is going to be a net detriment. And then the systemic vascular resistance, also called TPR, this is going to increase. Again, this is the sympathetic nervous system trying to increase the blood pressure. Treatment here is just IV fluids, right? Hypovolemic shock, not enough fluids, just give people fluids and that should hopefully balance it out. Cardiogenic shock, whether it's MI, heart failure, or an arrhythmia, your heart rate is going to increase for same reasons. The sympathetic nervous system, the catecholamines are going to try to increase cardiac output. Cold for the same reasons, you're redistributing away from your extremities and towards your visceral important organs, and your sympathetic nervous system causes clamminess. Really everything here is the same, other than what is the pulmonary capillary wedge pressure. So if it's the left part of the heart that's not working, this should be up because we can't get blood into the left part of the heart. So the pulmonary system is going to be backed up and it's going to have more fluid and more pressure. And if it's the right part of the heart that's failing, and usually the left side leads to the right heart. So if it's progressed to right heart failure, we can't even get it into the lungs in the first place. And so in that case, we might have a decrease in pulmonary capillary wedge pressure. Again, heart's not working, cardiac output's going to be down, and we're going to try to vasoconstrict to increase the blood pressure. Same deal for obstructive shock. I'm not even going to go over it again. If the obstruction's on the left side, maybe there's a clot in the pulmonary veins, or excuse me, if it's a clot in the pulmonary veins, that means there's more fluid in the pulmonary system, and that is going to increase. If the clot is in the pulmonary artery, right, as you're entering the pulmonary circuit, now the pulmonary capillary wedge pressure is going to go down. And here, increased contractility, maybe get rid of the fluid to, a lot of times this is going to cause edema. We want to get rid of that. Here, relieve the obstruction. Was it a pneumothorax? Is it pulmonary embolism? Do we need, thrombolytics? Now, honestly, all of these three above are very similar, and you'd do well by yourself to remember that. Distributive shock, whether it's sepsis, anaphylaxis, or CNS injury, the heart rate is going to go down. And that's we can probably best explain it by thinking about the central nervous system. You don't have the sympathetic response, so the catecholamines cannot increase the heart rate. The massive vasodilation and redistribution of blood in ways that are inappropriate means that maybe more blood's going to your skin and less to your brain and heart and lungs and liver. And so your skin's going to be, your extremities are going to be warm. We don't necessarily want them to be warm, but they will be warm. The pulmonary capillary wedge pressure should be down, the cardiac output. Now, for the most part, I think if we consider this from a central nervous system perspective, the cardiac output should be down because we cannot induce increased contractility and heart rate with catecholamines. You can with sepsis anaphylaxis, which is why the cardiac output might go up. And then the systemic vascular resistance is going to go down. Remember, the main thing that unites all of these is there's a, vasodilation, and inhibition of vasoconstriction, which is really just a vasodilation. So one way to think about all of this is that these three are effects. We have not enough fluid, heart's not working, or a block, so we have low blood pressure. So vasoconstriction is an attempt to increase the blood pressure. Those are effects. Those are secondary. The distributive shock, this is really what starts it, more or less. We have a vasodilation, which decreases the systemic vascular response, and then everything else is going to be secondary to that, is maybe an appropriate way to think about it. And Terminator 2, who could forget Miles Dyson? What type of shock is this? Hypovolemic shock. He's been shot, and you can see the sympathetic nervous system is kicking in. He's clammy. He's probably cold. His heart rate's probably kicking up. So we have some peripheral baroreceptors. So in the carotid, you have baroreceptors to sense the pressure. So this is for pressure regulation. And in the aortic arch, we also have baroreceptors. And these can feed information back to the central nervous system, which will inform what the vagus nerve does and what the sympathetic response is in terms of constriction, in terms of the heart rate, in terms of the contractility, etc. So if our arterial pressure did go down, this would cause a decrease in baroreceptor firing in the aortic arch and in the carotids. This would increase sympathetic response, decrease vagal response, which will have a net effect of increasing the cardiac output via increased contractility. The phase 4 is going to increase for our pacemaker cells, and the contractility will increase for various mechanisms we'll talk about. It's also going to cause vasoconstriction to increase the systemic vascular resistance to try to get back to normal. And negative feedback, I don't know whether it's positive, there should be negative, is eventually going to sort of fix the system, and then we'll stop whatever these shifts were. And what happens if we have a carotid massage? So if you apply pressure to the carotids, this will increase the pressure. This increases the stretch of the baroreceptors, which increases their firing rate. And this is going to cause a parasympathetic slowing of the heart. So upregulating parasympathetic and decreasing the sympathetic response. So we can further fine-tune local blood flow by vasoconstriction and vasodilation. And it's sort of almost like a buffer is a better way to think about autoregulation. So if I have ridiculously low blood pressure, the mean arterial pressure in, let's say my kidneys is just not going to be enough. It's maximally dilated. It's trying as hard as it can, but there's just not enough pressure. And if I have too much blood pressure, it's constricting as much as it can, but it's still not going to be able to fix this. The idea, though, is to maintain a constant amount of flow, is that as I increase the mean arterial pressure here, by making this smaller and smaller and smaller and smaller and smaller and smaller, I'm actually going to make sure that the overall flow is going to remain constant. So I might have said a pressure earlier and I misspoke. The blood flow will stay constant due to the alterations in constriction and relaxation, dilation and narrowing of the blood vessels. And again, this only works as a little buffer zone here. At a certain point, the blood pressure is too low, and so the flow is going to be too low. At a certain point, the blood pressure is too high, and there's going to be too much flow. But again, we're regulating the diameter in response to this changing pressure to keep the flow consistent. So a lot of molecules are going to help regulate and buffer the blood pressure. So what causes this? How does it know how to do this? A lot of it is CO2. So you can imagine if we produce a lot of CO2 and then we notice that the CO2 is kind of lingering around the tissues, it must be that we're not getting enough blood flow because the blood's supposed to come in and wash the CO2 away. So if I notice in a local level that my CO2 is high, I might choose as that organ to vasodilate, to increase the amount of blood that's coming in. On the other hand, if I have a low O2, this one should be more obvious even, amount of low amount of O2 is going to say, hey, I'm not getting enough oxygen. I probably could use more blood flow. So it's going to dilate the area so more blood comes in. And that's what we're seeing here, is that a higher amount of CO2 would cause vasodilation and a lower amount of O2 would cause vasodilation, the reverse for vasoconstriction. Arterial blood flow, and so if we look at the peripheral chemoreceptors, these are going to interact with oxygen and interact with CO2. So oxygen and CO2 for peripheral chemoreceptors. The central nervous system chemoreceptors, which can measure CO2 in the cerebrospinal fluid, I just said it, will only do CO2. So they do not do oxygen in the central nervous system, mostly the medulla here. And chemoreceptors that are encountering, lots of receptors sort of go on strike. If you have too much sugar throughout your life and there's too much insulin receptor, too much insulin receptors being summoned, this is going to blunt the response of the insulin receptors. Same thing here is that if you are chronically high CO2, the chemoreceptors are going to go, we're being overworked, we quit, they're going to go on strike. So the blunted response means that now actually you're going to be more reliant on oxygen receptors and less reliant on carbon dioxide receptors. Recall, though, that CO2 through carbonic anhydrase is converted to carbonic acid, which makes bicarbonate and H+. Also recall from Gen Chem 2, we have Le Chatelier's principle. If you increase the amount of CO2, you increase the amount of H+, which means you're decreasing your pH. So a lot of times these receptors, sometimes they interact with CO2, but I would say more often than not, they're going to just directly interact with the H+, which is effectively a proxy, an indirect measurement of what the CO2 is. So in our arterial blood, if we have large CO2, I'm going to have a large H+, which means I'm going to have a low pH. And the chemoreceptors can detect this, and they will assume that if I have a large CO2, it means that I'm not ventilating enough, and it will increase my ventilation rate until things get back down to normal, in which case negative feedback will then stop the initial stimuli that change the system. The exact opposite in this scenario. As long as we work the opposite of what we mentioned earlier. So earlier we said, look, if there's not enough oxygen in an area, we're going to vasodilate because we want more blood to flow in that region to bring oxygen in. Here we're going to say that lungs work in the opposite manner. If I don't have enough oxygen coming to this set of alveoli, it's a completely different scenario. It's the waste of your blood to go to that alveoli if it's not bringing in oxygen because it wants to pick up oxygen. So we're actually going to constrict this here and say, don't waste your time. It's not worth the squeeze. So we're not going to send a lot of blood to that particularly alveoli, and we're going to increase blood flow to the other alveoli. So this is called hypoxic vasoconstriction, and it's very important both for the pulmonary unit and also we'll see it time and time again in this cardiovascular unit. Natriuretic peptides, so hyponatremia is hypo, not enough, sodium, and emia, blood, so not enough sodium in the blood. Sodium uretic just means like diuretic, peeing a lot effectively. So these are helping us pee out sodium. This is the opposite effect of what we saw with the renin-angiotensin-aldosterone system. Mainly, aldosterone helps us retain sodium in the distal convoluted tubule, which means we're going to increase the amount of blood volume, which means we increase the blood pressure. So this is doing the opposite. It is decreasing the sodium reabsorption. Therefore, we get less water and less pressure. It's also just going to counteract directly the vasodilation. It's going to cause vasodilation, which counters the vasoconstriction that angiotensin 2 induces. A and P comes from the atria. B and P, B is for brain, but that's just where it was discovered. It's really from the ventricles. So A and P is from the atria, B and P is from the ventricles. B and P has a longer half-life, and it's part of the diagnostic workup for heart failure.